It's 2:47 a.m. Your phone screen is the only light in the room. You're staring at the words, low-risk prostate cancer. Then you remember what your doctor said, almost casually, active surveillance. And your brain translates that into, so we're doing nothing about cancer? And that's when panic does what panic always does. It recruits Google. One search becomes 40 tabs and every headline sounds like either you're totally fine or you're delaying a ticking time bomb. Let me stop the spiral right here. Active surveillance does not mean ignoring cancer. It means monitoring it closely with a structured plan and treating it only if the evidence shows it's changing in a way that matters. Monitoring, not ignoring. In the next several minutes, I'm going to make this simple and usable. You'll understand what active surveillance really is, who it's for, what the schedule typically looks like, what triggers action, and the exact questions you should ask so you walk out of your appointment with clarity, not panic. First, what active surveillance actually means, plain English. Active surveillance is a management strategy for certain prostate cancers, most often early stage and low risk, where you don't start treatment immediately. Instead, you follow a plan of regular checkups and tests to catch any meaningful change early. The whole point is to avoid or delay treatments like surgery or radiation when they may not be necessary right now without losing your safety net. Now, people confuse active surveillance with watchful waiting, and that's where fear sneaks in. Think of it this way. Active surveillance is proactive monitoring. With a cure window in mind, you're watching carefully so you can treat in time if risk changes. Watchful waiting is often less intensive and may focus more on symptoms commonly used when other health factors or age make aggressive treatment less appropriate. If your doctor said active surveillance, the key word is active. So why do doctors recommend it? Because prostate cancer is not one personality. Some prostate cancers behave like a slow-moving turtle. Others move faster. Active surveillance exists because many prostate cancers, especially low-risk ones, can grow so slowly that immediate treatment may not improve outcomes for everyone, but treatment can still carry real trade-offs, and those trade-offs matter. Surgery and radiation can be life-saving and absolutely the right choice for many people, but they can also affect urinary control, sexual function, bowel habits, and overall quality of life. Active surveillance is designed to reduce overtreatment, treating cancers that might never cause harm while still keeping you safe through close monitoring. Now let's answer the question everyone wants answered. Am I the kind of person who's a fit for active surveillance? I can't decide that for you. That's between you and your care team, but I can tell you what doctors typically look at. They don't base this on one number. They look at a dashboard. Your biopsy grade, often reported as grade group or Gleason pattern, how much cancer was found on biopsy, PSA and PSA trend over time, prostate imaging such as MRI, your age, overall health, family history, and your preferences. The bigger point is this. Low risk is not a vibe. It's a combination of findings. Let's break down the key tools, because understanding the tools reduces fear. PSA. Most people treat PSA like it's a truth serum. It's not. PSA is a signal, and signals need context. PSA can move for reasons that aren't cancer progression. That's why doctors care about trend more than one snapshot. A single bump is not automatically a disaster. It's a reason to look at the bigger picture and, if needed, repeat testing or add imaging. Digital rectal exam? Yes, it's old school. And no, it's not fun. But it can add information over time when combined with PSA and imaging. MRI. MRI became a big deal because it can help identify suspicious areas and guide targeted biopsies, helping reduce the sampling problem. Which brings us to biopsy. A biopsy samples tissue. It doesn't scan every cell of the prostate. Imagine checking a huge lawn for weeds by looking at a few small patches. You might miss the weed cluster on the other side. That's why many active surveillance plans include a confirmatory approach, sometimes an MRI, sometimes repeat biopsy, and then ongoing surveillance. The goal is to make sure the original low-risk label is accurate and stays accurate. Now, here's the part that should be written down in big letters. What triggers treatment? Active surveillance should never be, we'll just see. It should be, we monitor, and if X happens, we do Y. Common triggers doctors consider include a biopsy that shows the cancer grade has increased in a meaningful way, MRI that shows a new or more concerning area, evidence that cancer volume is increasing, like more biopsy cores involved or higher percent involvement, and PSA trends that, in context with MRI and biopsy, suggest higher risk. In other words, it's not one lab value, it's a pattern supported by evidence. Here's the healthiest mental model. Active surveillance is like having a smoke detector system with rules. You don't evacuate the house because the detector chirped once. But if the alarm repeats, you smell smoke, and you see haze, now you act. In prostate care, PSA trends plus MRI plus biopsy changes are your alarm system, and your doctor should tell you exactly what changes would trigger action. Now, let's talk about the biggest myths, because myths are gasoline on anxiety. Myth number 1, active surveillance means doing nothing. Truth, it's a structured plan with regular monitoring. Doing nothing would be skipping follow-ups. Active surveillance is the opposite. Myth number 2, cancer always spreads fast. Truth, prostate cancer biology varies. Many low-risk cancers progress slowly enough that close monitoring is safe for carefully selected patients, especially when you follow the schedule. Myth number 3, if I don't treat now, I lose my chance. Truth, the entire purpose of active surveillance protocols is to detect meaningful changes early enough to treat while the cancer is still curable. The risk goes up when people disappear from follow-up, not when they follow a proper plan. Now, let's make this extremely practical. What does a monitoring schedule actually look like? Schedules vary by clinic and by your specifics, but many programs include PSA testing about twice a year, periodic MRI, and repeat biopsies at longer intervals, with earlier testing if something changes. Some major cancer centers describe a usual schedule like PSA every 6 months, MRI around every 18 months, and surveillance biopsy about every 3 years, adjusted if PSA or MRI changes. The point is not to copy-paste someone else's schedule. The point is, there is a schedule. There are checkpoints. If your doctor says active surveillance, your next question should be, great, what's my exact schedule? And what are the triggers that would make us treat? Now, let's address the hardest part that no one talks about enough, the emotional weight. Even with low-risk cancer, the word cancer can hijack your nervous system. You can feel calm at 10 a.m. and terrified at 10 p.m. That's normal. Your goal isn't to never feel fear. Your goal is to prevent fear from running your decisions. Here are a few practical strategies that actually help. Strategy 1. Replace vague fear with specific questions. Fear loves uncertainty, clarity kills it. When you have written answers, your brain stops inventing worst-case scenarios. Strategy 2. Track trends, not headlines. Your care plan is based on your data over time, not a random story you saw online. Strategy 3. Make a decision document. 1 page. That's it. Put your diagnosis summary, your plan schedule, and your triggers for action. This becomes your anxiety shield. When you feel panic, you read your plan. Strategy 4. Consider a second opinion when it would calm you. Not because your doctor is wrong, because sometimes hearing the same plan from a second expert lowers anxiety and increases confidence. Confidence increases adherence, and adherence is how active surveillance stays safe. Now let's talk about what you can control while on surveillance without falling into miracle cure hype. You can't control every cell, but you can control follow-up discipline, lifestyle foundations, and communication. Lifestyle doesn't replace medical monitoring, but it can support overall health and resilience. Stay physically active in a way you can sustain, prioritize sleep, manage stress, and eat in a way that supports heart and metabolic health. Avoid supplement hype culture that promises to cure cancer. If something sounds like a secret the entire oncology world missed, it's usually marketing. Now, here's the most valuable part of this entire script, the checklist. If you do nothing else, bring these questions to your next appointment and write the answers down. What is my grade group or Gleason pattern? How many biopsy cores were positive? What was the percent involvement in the positive cores? Was there any higher grade pattern present? What is my PSA trend over time, not just the most recent number? What is my PSA density, if available? What did MRI show? If done, was anything suspicious noted? What is my clinical stage? What exactly will trigger treatment in my case? When is my next PSA, MRI, and biopsy scheduled? When you have these answers, you stop guessing and you start planning. And that brings us back to the original question, safe choice or dangerous delay? For the right patient, with the right risk profile, and a properly followed monitoring plan, active surveillance can be a smart, evidence-based approach that protects quality of life without compromising safety. The danger isn't the word surveillance. The danger is the absence of a plan or ignoring the plan. So here's your takeaway. Active surveillance is not denial, it's strategy. It's monitoring with rules. And if your mind tries to catastrophize at midnight, remember 3 words: plan, trend, triggers. And if you're watching this with 43 tabs open, let me write your official prescription. Close the tabs, drink some water, and let your plan not panic run the show. If you found this helpful, subscribe to Nourish today. We take scary medical topics and turn them into calm, clear next steps. And a quick legal reminder, this video is for education only and is not medical advice. Always discuss your results and treatment decisions with your urologist or healthcare team.
Thanks for watching. Stay informed, stay calm. Subscribe for calm, evidence-based health here on Nourish Today.